We still have a couple more speakers, and it's a pleasure for me to introduce now our third speaker, Associate Professor Judith Trotman, who is a haematologist here at Concord, an active clinical trialist, and she's going to talk to us today about what happens when the disease returns. Thank you, Judith.
Okay, perhaps while we get the slides together, Sharon, I'd like to give my personal thanks to Professor Frunschhoff. Every time I hear him speak, I learn something new, and I could admit to my shame, I didn't know that the B lymphocytes came from the bursa of birds originally in terms of their naming. I always assumed that the B came from bone marrow. So there you go, I've learned something extra today. I didn't see Michael's slides, and he hasn't seen mine, so again I have to thank him for the big plug for clinical research, because certainly that's something that I'm very passionate about supporting in the management of patients with lymphoma. Do I just press this down arrow, I think? Certainly when if your lymphoma relapses, it's a very confronting situation, but it's still, as Professor Frunschhoff has explained, a very treatable disease. And today I'd like to talk about the practicalities of current management of relapsed lymphoma, but also share with you my optimism about the exciting new research breakthroughs that are really happening right now in the management of lymphoma, led by the German lymphoma study groups, the French lymphoma study groups, and our own Australia Leukemia Lymphoma Group research. Perhaps we should just remember a little bit of Lymphoma 101, though, and a little bit of basic terminology. When you're treated for relapsed lymphoma, indeed when you're first treated at diagnosis for your lymphoma, there are terminology that is applied. If the disease is refractory or growing during chemotherapy, that's obviously a very serious problem, but fortunately is certainly very rare at initial therapy, but becomes increasingly an issue after you've had multiple relapses, perhaps of your low-grade lymphoma. Stable disease implies that it's less than 50% smaller from when you first started treatment. A partial remission demonstrates more than 50% reduction in the volume of the nodes, but there's still an enlarged node present. And perhaps the holy grail of the initial treatment approach is to achieve a complete remission where we can't see the lymphoma if we use our CT scans, our PET scans, and our even more sensitive sometimes bone marrow tests to demonstrate bone marrow clearance of the lymphoma if it was there. Beyond achieving a remission, certainly we all want to make prognostications, but it's really only Dr. Time who will determine whether you are cured. Relapse is the term that is applied to the disease that recurs after you've achieved a complete remission, whereas you might also hear your doctor talk about your lymphoma has progressed, and progressive disease is regrowth of the lymphoma after having achieved either a stable or a partial response. And relapsed lymphoma is certainly still a very treatable disease, in particular if that relapse has come a lot later than the initial treatment and if the patient is fit and well enough to have additional therapy. And second, third, fourth, even sometimes fifth remissions can last 4 months to years. And indeed, for some types of lymphoma, the goal can still be to cure that lymphoma even after it's been relapsed. And I'd like to reiterate what Jason has said today and the message that you've got from Professor Frunschhoff. The treatment that we can offer you in 2013 is very much based on the enormous advances. It's been very exciting to be a lymphoma doctor because of the clinical research that has occurred in the last 2 decades. So when I think about how I'm going to approach a patient with relapsed lymphoma, I think of the 4 Ps of prescription. And the 4 Ps relate to, firstly, the previous treatment that the patient has received, the pathology, the type of lymphoma that they have, where it is at relapse, what various prognostic markers may be in play, and the patient. Clearly, their age and fitness are important, but also at relapse disease, there might be a realignment of patient priorities, other illnesses that are starting to come into play, and certainly that needs to be taken into consideration. Now, here in Australia, I like to think that the average haematologist is not Dr. House, difficult to communicate with, psychotic, brilliant person, but a well-read doctor who understands the nuances of the various different types of lymphomas and appreciates that in the context of the healthcare structure that we have here in Australia. And certainly for centres where there are many haematologists, I think it's quite important and quite reasonable for you as patients to be asking your haematologist about whether there is multidisciplinary team peer review of your management at relapse. And this is an example of a snapshot of our pro forma that we have here at Concord, where the treating haematologist is obliged to complete the diagnosis and management workup of the patient at relapse, propose what their management plan is, which is then debated in a peer review setting before the final management plan is posted off to the general practitioner. So now let's focus on the different types of lymphoma. Now, you've already heard about Hodgkin lymphoma, and clearly for Hodgkin lymphoma there are two standard frontline therapeutic approaches. And at relapse, generally speaking, the patient receives a different chemotherapy regimen, and that often includes gemcitabine. Can I grab a glass of water? Thank you. If the patient is young and fit enough, it's very common when they have had a response to that salvage, that second-line chemotherapy, to go on to receive, thanks so much, Beth, what's called high-dose chemotherapy. A very intensive chemotherapy designed to effectively wipe out the lymphoma, but unfortunately the normal healthy bone marrow gets wiped out as well, and the patient's hemopoietic recovery, their ability to make blood, has to be rescued by the reinfusion of stem cells. But what is exciting in the arena of Hodgkin lymphoma is an emerging antibody called brentuximab, or Adcetris. And that is an antibody directed against the CD30 protein on the surface of the lymphoma cells. And it's not directly toxic to the lymphoma cells. It actually delivers a toxin that then enters and destroys the lymphoma cells. And I've had experience with use of brentuximab. It's a very promising agent. We've got some issues with the fact that it is toxic. It's a tubulin toxin, and it causes some problems with peripheral neuropathy. But we're getting a sense of how to manage that and dose adjust to manage the numbness that can occur in patients' hands. It's certainly a very expensive agent and is not yet approved or funded, publicly available in Australia. Now, Michael has discussed the low-grade, the indolent lymphomas, of which the vast majority are follicular lymphoma. And he's alluded to the fact that these are traditionally incurable, but our concepts of cure are now very much challenged, because with the exciting new therapies and the prolonged remissions that patients with indolent lymphoma can have, many patients are dying with rather than of their lymphoma. And of course, that has enormous physical and psychosocial implications of living life with a chronic cancer. So one can sometimes, when you're a patient with follicular lymphoma and you've done a little bit of reading on the internet, feel like the decision about your treatment is very much based on the spinning of the wheel of fortune. But I can assure you, come back to the 4 Ps. Your physician will determine what they feel is the most appropriate treatment for you based on the site of the relapse, based on the pathology of the lymphoma and its prognostic features, and clearly also based on your previous treatment. But there are some simple rules of thumb for follicular lymphoma. It's important, if the lymphoma seems to be growing back a little bit faster than otherwise normally would happen for follicular lymphoma, to repeat the biopsy and exclude a transformation, a changing of status of the lymphoma into a more aggressive type of lymphoma. but generally speaking, most patients will once again receive the rituximab antibody along with chemotherapy. And then generally, if they have not shown any evidence of being resistant or refractory to rituximab, obviously then they won't receive rituximab, but generally they will then go on also to receive the rituximab maintenance therapy. If the patient hasn't had CHOP before, we would add CHOP into the regimen perhaps, and if their heart is good and they can tolerate that H part of the CHOP that I've listed there. But certainly bendamustine is a very useful agent for patients with relapsed lymphoma. And while at least 30 of the patients at Concord Hospital have received bendamustine in frontline therapy in the context of clinical trials, we do have a number of patients who actually are choosing to pay themselves for bendamustine in the relapse setting, because the Germans have given us some excellent data that demonstrates how good it is at the treatment of follicular lymphoma. Unfortunately, I'm sure Michael alluded to the fact of how expensive bendamustine is now. I can assure Michael it's a lot more expensive in Australia by the time the distributors have imported it over. However, we are hopeful that this will actually be listed on the TGA, approved by the TGA and listed on the Pharmaceutical Benefits Scheme, perhaps as early as next year for Australian patients. I think it's also important to consider that no treatment may well be the appropriate treatment, not just at diagnosis, as Michael referred to, but also at relapse of the follicular lymphoma, because I have had patients whose relapse has occurred, but they have gradually progressed for years before I've actually had to jump in and treat their disease. The timing, the art of medicine is working out when to retreat the lymphoma before it starts becoming too difficult and too burdensome, to sort of miss the boat. Now, autologous stem cell transplantation is certainly an important consideration for patients who are young and fit enough to have autologous transplantation as a means of consolidating the remission that has been achieved after their initial treatment for their relapsed lymphoma. And radiotherapy also has an important role for the management of local relapses. It's important that you ask your doctor whether there is any potential to access the promising new agents, the enzymes adalimumab and ibrutinib, that are targeted against the receptors, the B-cell receptors on the surface of the lymphoma cells, that are very, very well tolerated and show great promise in the management of relapsed lymphoma. And also our own ALLG study is looking at using lenalidomide in patients who continue to be PET positive after the treatment of their relapsed follicular lymphoma. Moving on to the relapse of aggressive lymphoma, as you're already aware, the vast majority of patients have diffuse large B-cell lymphoma, but I think it's fair to admit that the real Achilles heel of lymphoma management are the T-cell lymphomas, of which there are numerous types that are all quite rare, but have particularly difficult and disappointing prognosis once they have relapsed. The highest risk of relapse is certainly in the first couple of years after treatment, and there are several quite comparable chemotherapy approaches. I know DAP is the most commonly used regimen in Germany, and DAP and RICE are certainly very commonly used here in Australia. But GDP is increasingly being considered, as it's also shown to be quite efficacious and also a very good outpatient-based treatment for relapsed lymphoma. And most patients, once again, if they're young, and I refuse to define young here today, and if they're fit enough, will go on to have that remission consolidated after a few cycles of chemotherapy with the more intensive chemotherapy and stem cell transplant. But once again, I reiterate that a clinical trial participation is often the first-line option, particularly for patients with T-cell lymphoma. So, chemotherapy is still a common option. But now we have a lot more, and this is the part of the talk that I'm looking forward to. All right, research is moving us away from the blunderbuss chemotherapy approach, from the chop that Michael alluded to, that he had to battle with for 20 years before rituximab antibody therapy came along. We're moving now to adding in smarter, targeted therapies that are quite specific for the lymphoma cells. We've now had a decade of rituximab anti-CD20 antibody, but I'm hoping that not only in the chronic lymphocytic leukemia arena, but also in the arena of relapsed B-cell lymphoma, we're soon going to see a new anti-CD20 antibody which has a different mechanism of action against this protein that is expressed by the B-cell lymphomas. Also, brentuximab, this antibody directed against CD30 that I mentioned before, is not just present on Hodgkin lymphoma cells, but is also present on some T-cell lymphomas. And there's some very promising data on the use of brentuximab in T-cell lymphomas. And I have a young patient in his 40s who's now up to his 11th cycle of brentuximab for his relapsed T-cell lymphoma and tolerating it very well. And every time I come in, he walks in saying, "No, my numbness is no worse this time than it was last time." So he does have a little bit of peripheral neuropathy, but it certainly is not affecting him functionally. Lenalidomide is a drug that's we've got considerable experience with in the management of myeloma, but is an immune system modulator that enhances the natural killer cell and T cells' own surveillance and control of the lymphoma. That is also showing great promise in relapsed and indeed in some trials upfront treatment of follicular lymphoma. And again, I've already mentioned ibrutinib and idelalisib, which are very specific B-cell receptor inhibitors that are showing great promise, and in particular, very little toxicity and oral, easily taken capsules for the management of relapsed lymphoma. For those of us who get a little bit frustrated about reading on the internet about all these exciting new agents and the delay in accessibility of these agents, I need to remind you that the drug development timeline often extends beyond 10 years. We all admire the laboratory test tube scientists, the rats, the guinea pig research, and the breakthroughs that are so often mentioned in the Sydney Morning Herald and other media. And that preclinical research and development takes at least a couple of years. And then there's the time frame of the clinical research and development, which I've sort of used the stop-go signs as a means of illustrating to you the three phases of clinical development. The phase 1 clinical trial is a study of maybe 10, 20 patients where the drug is given, the new medicine is given in increasing doses to determine that it is actually safe to administer to humans. Once safety has been determined and the ideal dose has been determined, it is then that the clinical trial moves on to a phase 2, where the patients are given what is predicted to be the ideal dose to demonstrate whether or not the drug actually works against the lymphoma. And if it's shown to have promising activity against the lymphoma, then most federal agencies will not approve the release of a new drug unless it has been demonstrated in a large, generally with many hundreds of patients, phase 3 study, which compares that new medicine, potentially promising medicine, with what we would consider was the best standard of care. So you can appreciate why it takes so long for new medicines to come actually into the clinic. So what is good clinical research? It's research that asks the right question. It's about the questions that are important to us as a lymphoma community, that answers the priorities that we have. It's ethically justifiable and conducted ethically, and there is an international code of good clinical practice that ensures that happens. It's got to be statistically robust. it's got to be able to ask a question that can reliably be answered with minimal bias. And so to put in one rather complex sentence, a clinical trial is a carefully designed study conducted under the code of GCP that seeks to determine under controlled, under carefully monitored conditions, the safety and effectiveness of a new treatment method. And it's clinical research that allows the laboratory breakthroughs to be translated into our clinical practice. Now, Professor Frunschhoff has already sort of alluded to this, but I think I'm going to give the message again because I think it's an important message to give. Why would you as a patient want to participate in clinical trials? Well, clearly there's hopefully a direct benefit to you from the studied therapy. And even if you were on the placebo arm or the standard of care arm, research has demonstrated that patients do better even when they're receiving the standard treatment because of the close monitoring that they get when they're participating in a clinical trial and the general adherence to the protocol. There's clearly a benefit to the advancement of medical science and a benefit to future patients in speeding the development of effective therapies and stopping the development of ineffective therapies. And for us at Concord, one of our great motivators, and I know my colleagues in Queensland and Mark Hertzberg at Westmead, one of the big motivators for participating in clinical trials is that we get much quicker access to the therapies that are not available on the pharmaceutical benefit scheme yet. And bendamustine has certainly been an example of that for us. But it's also important to ask why don't participate in a clinical trial. And I think the number one reason is because you and your clinician decide that the question that is being asked is not the right question for you. The direct risk of participating in a study and the potential toxicities, as much as one can try and predict, must be acknowledged. And it's generally a lot easier just to have the standard of care or what you may perceive to be best practice as what is recommended to you by your haematologist. Participating in a clinical trial and reading that 20-page informed consent document is often just a bit too much for patients to be thinking about when they're literally just dealing with the diagnosis of lymphoma and learning how to spell it, let alone read a long informed consent document. It's important always to ask who really benefits from this, the sponsor or me, and ideally with most clinical trials we like to hope that it will be both who benefit from study participation. And for patients who are in phase 3 trials where they may be randomised to standard of care, I think it's important for them to ask, what are my options? Will I get access to this study drug if it's proven to be efficacious afterwards, after the trial has been completed? And it's important to acknowledge there is always potential for conflicts of interest. But notwithstanding that, I think it's important that we as a lymphoma community try and be out there to counter the negative public perceptions that exist about trials. Here, we don't have a trials unit. Here we have renamed our unit the Clinical Research Unit because of the positive connotations that the word research have and the negative connotations that trials have. And I have to explain to my patients very often the difference between them and the guinea pig is that for the guinea pig, for the laboratory rat, the research is the priority. Whereas for them, their care is the priority, and the clinical trial is simply the way that I feel that our colleagues and I feel that we can deliver that best care to them. And patients who participate in a clinical trial will only continue to participate in that trial as long as it is perceived to be the best care for them. And once you sign a consent form, it doesn't mean to say you're locked into that trial for the next 10 years. We recently, just 12 weeks ago, launched ClinTrial Refer, which is a mobile application to connect clinicians and their patients to clinical trials. Now, this is free for anybody to download from the App Store if they have an iPad, an iPhone or an Android. And it provides an easy-to-navigate listing of the currently recruiting trials within New South Wales and the ACT. On the left here, you'll see that we have these key search filters of disease and location, where we can, because it's hematology, not just lymphoma specific. And on the right here, I've got, once you've drilled down to a specific study, we're participating in an international collaboration, the REMARK study with our French colleagues. And when you click on that particular trial, you can see the inclusion and exclusion criteria. And just released in the latest update of the app, we've added a lay summary for patients to learn and understand about the trial. And we have, in the 12 weeks since we've launched this app, a huge increase in cross-referral of patients across New South Wales to trials that is very important, because no one hospital can possibly provide a portfolio of clinical trials for every possible lymphoma histology. Victoria Haematology are going to go live next month with their app. And we are very excited about Clinical Trials Refer, the potential it has to expand patients' access to clinical research. So I've got here a few little conversation starters that you might like to think about when you meet your haematologist in the clinic, when you're discussing the relapse of your lymphoma, which I hope most of you never have to do. How has my lymphoma changed? Will my case be assessed at a multidisciplinary team meeting? What are the treatments available now? Because for most patients, there's always going to be one treatment, but for some patients, there may be many. And what are our treatment goals now? Is not treating the lymphoma for the moment a reasonable option? Do you have any clinical trials that I would be eligible for? And how will we assess my response to treatment? Who will be my care coordinator? And who do I call if I get unwell? I think there are certain challenges that I experience in communication during the busy clinic list. And I'm always trying to get a sense, because every patient is a bit different, about how much or how little they wish to know. And I suspect sometimes my patients get overloaded with a bit too much information than they actually want from me. I encourage you all to remember your questions and bring them written in on a piece of paper into clinic with you, because you always remember them the moment the door is shut after you've left the clinic. At doctors, we risk being far too technical and creating confusion for our patients about the treatment schedule. But increasingly, I'm seeing patients come in their first appointment with me who are being far too technical themselves before they've learnt the basics about lymphoma, and I suspect that's because of Dr. Google. Oh, going the wrong way. Other challenges I find, Australia is a very multicultural society, and we often find family members are gatekeepers for patients who have English as a second language. And the other situation where family members will often be well-meaning gatekeepers is when the patient actually has a poor prognosis. I'm sorry, I am finding it very difficult to keep up with all the latest and greatest clinical research developments in lymphoma. I have very little knowledge about alternative therapies, and that's something that I struggle to, and yet at the same time I'm not sure I am required to know about. Giving a prognosis is challenging. It's calculated guesswork that is often proven wrong, because for a relapsed follicular lymphoma, if the average survival is 5 years, you'll probably have 10% of patients who won't survive more than 1 year, and another 10% of patients who will survive more than 12 years. And so most patients are not the median. The doctor who doesn't have enough time is certainly a common complaint within the public health systems within Australia. But I think you need to ask, do you want a doctor who's always on time for you, or the one who will squeeze you urgently into the clinic when you're unwell? Remember, the 10-minute appointment is often balanced by the 40-minute appointment, and there is an awful lot in the management of your lymphoma that goes on behind the scenes. Corridor discussions are fraught with challenges because they are always brief and incomplete, and I think the busy doctor is often perceived as the doctor who does not convey enough empathy. I'm really looking forward, Mirren, to your talk about managing and living with lymphoma, because I think it's important that we as haematologists recognise there are clearly not just the physical side effects of the treatment, but the psychosocial side effects, and in particular the lack of trust in your own body that occurs after your lymphoma has relapsed, and living with that great uncertainty of your prognosis. The elephant in the room is always when things are not going well, and I was really impressed by this Journal of Clinical Oncology article, which was quite confronting in its title, Pessimism is No Poison. I think when the treatment pathway is getting more and more difficult for us as lymphoma physicians and lymphoma patients, I think it's important that we acknowledge that, because patients wish to be informed, and prognostication, while it's very challenging, is needed both for medical and social decision making. And there's been a lot of research on this, and it's well recognised that there is a soft paternalism that exists within haematology and oncology, where we protect patients from bad news, and that may protect them in the short term and bring short-term benefits, but potentially can cause long-term harm. And it's actually, I find, when I'm acknowledging my concerns about the difficulties in managing the lymphoma and controlling the disease, that actually earns a patient's trust. For that point, I think it's important to remember that after relapse, while one always must have hope, the goals do sometimes change. From perhaps complete remission and cure to survival until a personal milestone, or comfort and dignity during one's final months. For us as haematologists, it's a very delicate balance between fostering realistic hopes and not peddling false expectations. But I have to say that for me, the joy of lymphoma care comes not just from the rapid advances in bringing research into practice, but how often my poor prognosis patients delight in proving me wrong. And I'd like to thank you all for your time, and encourage any of you who are Concord locals to join us for a bloody great night out to raise funds for our research unit here. Thank you very much.
Thanks, Judith. That was a great expose for patients about practicalities of treatment and communication. I'm wondering if there are any questions that people would like to pose to Dr. Trotman.
I think everyone would like some afternoon tea.
I think they might in a minute. Okay, so...
More than happy to answer questions
okay,
over
afterwards,
a cup
yeah.
of tea.
A lot of people might like to come up and speak to any of the speakers at afternoon tea, and I think we can move on. So thank you again to Judith.